Okay.
Okay, thanks. So yeah, we'll just have another minute or so of waiting, and then we'll get started. So we can start recording. Get going. So welcome everybody. So Janina, I guess we can start recording now. Welcome everyone. Thank you very much for joining. I'm excited to have you all here. I think it's going to be an interesting talk. So my good friend and colleague Brian Chen is our speaker today. So Brian is an affiliate scientist with the NET team at TRI. He's also an assistant professor at the Institute of Health Policy Management and Evaluation at U of T. Brian received his bachelor's and master's degree in pharmacology at U of T, and then worked as a research assistant at the Health Outcomes and Pharmacoeconomics Research Center. He then came back to do his PhD, which he completed in 2017, on the economic burden of chronic ulcers. And as he was doing his PhD, Brian was employed as a health economist at Health Quality Ontario. And so Brian brings a very valuable expertise, I think, in looking at the economic side of a lot of the initiatives that we engage in. And so I think it's really grateful that he's willing to take his time and give us a talk on some of those concepts. So thank you, Brian. And so I'll turn the floor over to you.
Hey, thanks a lot, Jose. Thank you for that kind introduction. So a couple of things. First, I'm going to be actually trying a couple new things in this workshop. So do let me know afterwards. Email me if there were some things that worked or didn't work, and let me know so I know whether to do that for next time. We are actually going to do some hands-on things as well. So, so you may want to pre-open Excel if you want to use a spreadsheet, or pull up the calculator on your phone, because we'll be doing a bit of calculating. And we are actually going to also be using polls a couple of times in this presentation. So I'm going to start off with the first poll to get you warmed up on the use of it. I'm interested in seeing what your response is to that. Give a couple of seconds to respond to the poll. Leave it open for a couple more seconds.
Brian, as a co-host, it looks like I can't vote, so I apologize.
No, only me.
I've heard about these methods.
You have heard. Okay, good. Okay, so I'm going to end the poll. And it seems like, let's sharing the results. Seems like some of you guys have heard of these methods, and one person said you let your accountant handle it if you could, but that's what we're all here to learn about these methods. So the objectives for this presentation are very simple. We're going to talk about economic analysis and how they're conducted in healthcare. And then we're going to talk specifically on some of the challenges of conducting these types of analyses for monitoring technologies. I'd like to start off by telling you a story. So I don't know how many of you guys have ever watched that show, Till Death Do Us Part, reality show where there is a financial expert who's helping a couple who's having debt issues try and manage their finances. And one part of the show, she cuts up all their credit cards and then sets up these jars with certain amounts of cash in each of them. And they are in different categories where they can spend. So in entertainment and food and living expenses and whatnot. And it's interesting to see how the couples try to continue with their current way of life with now a limited budget. And in some ways that is kind of similar to our healthcare system. So the challenge for the government is to try and maintain or possibly even improve our health in our aging population, but on a fixed budget. So they can't go over budget, they have to stay within budget and provide the healthcare needed to keep everyone healthy. And so if there's a researcher such as yourself who finds a new intervention or a new technology that could potentially improve people's health or potentially even prevent complications from occurring, and you're very interested in having the government fund this intervention so that it can be used in long-term care setting or in home care, then the government needs to decide, with a given limited budget and a budget that's maxed, if we were to fund this new technology, then what do we have to take out of the system so that we have the funds able to provide this new intervention? So they have to think about this new intervention that you think is going to improve health, and think about cost and consequences of this of funding this new intervention, or even in other terms, the value for money. So if we were to spend money to fund this new intervention, what is the value we are getting out of it, and is it worth it? So there are a couple of economic analyses that are conducted that may get at this question in certain angles. Definitely the easiest or the simplest economic analysis is do a simple cost analysis, where you compare the cost of providing the intervention versus comparator intervention. And in the case where both the intervention and the comparator have been shown to be similar in terms of their efficacy or their effectiveness, then if both their outcomes are the same, then the only question that remains is which one is cheaper to deliver, and that becomes a cost minimization analysis. However, most of the time that's not the case, right? The new intervention may cost more than a current intervention being used right now, but it provides better outcomes. So how do we sort of balance the two? And that's where we do cost effectiveness analysis, where we balance the difference in costs with the differences in outcomes. So for instance, if there is an intervention that, let's say, prevents pressure ulcers, but it costs a lot more money, then what you are trying to calculate is the difference between the cost of the intervention and the cost of the comparator, and the difference in outcomes, this being pressure ulcers, in the intervention versus the comparator, and your result is a cost per pressure ulcer avoided. And this can be with any sorts of outcomes. So it could be cost per pressure ulcer avoided. It could be the cost of a 1-point reduction in A1C levels. It could be a cost per rehospitalization avoided, for instance. So you can see that depending on what the population is and what are the important outcomes in that population, you can have different costs per whatever that outcome may be. However, there's a problem with that. And the problem is, because there are so many outcomes, how do you compare if you were to make a choice between, a decision maker needs to make a choice between funding one intervention versus another, and their outcome is a cost per this avoided versus a cost per improvement in a function level? How do they decide which one is more attractive? And so there is a gold standard for a cost effectiveness analysis, that being the cost utility analysis, where the outcome is the quality adjusted life years. So this outcome sort of combines quality of life with the improvements in longevity of life between an intervention and comparator, and results in a cost per quality adjusted life year. And this, you can think that this spans over different types of populations, different types of interventions. So this outcome could be used for all sorts of interventions. And so you can have a single comparator and compare different interventions. And whichever has the more attractive cost per quality adjusted life years is maybe one that should take priority. There are also other types of economic analyses that don't look at what the cost effectiveness of an intervention is, there is the budget impact analysis, which shows if a government or a decision maker has to fund a new intervention, what would be the impact on their budget, on their healthcare budget in this case. So they would take a look at what the additional cost would be to be able to deliver an intervention, and then take a look at how large of a population would this impact. And then with the appropriate sensitivity analysis and ranges, they can get at an approximate budget impact, how much it would cost per year to fund a new intervention. Another type of economic analysis is the cost of illness study. And this is different from the other ones, because the other ones we have been focused on taking a look at the impact of a new intervention, or maybe even an old intervention, versus a comparator. In cost of illness, on the other hand, we are taking a look at the economic burden of a condition, of an illness, and taking a look at its impact on the healthcare system in terms of the financial burden. So we're taking a look at the illness as opposed to an intervention specific. So these are sort of the types of general economic analysis types that are typically used. However, in academia, in academic journals, you tend to see the cost analysis and the cost effectiveness analysis, and sometimes the cost of illness studies too. Very little, if any, budget impact analysis because of how jurisdiction specific they are. Okay, we are going to take a deeper dive into what has been called the workhorses in terms of methods for conducting cost effectiveness analysis, that being the decision tree and also the Markov model. So named after Andrei Markov, who's sporting quite a cool beard there. But in the decision tree, what we have is typical to what you think a decision tree is. So there are probabilities of individuals going into different arms or different branches. And over time, as there are more nodes occurring, then the person sort of falls into different branches of the arms with different probabilities, and they become conditional probabilities. For Markov models, on the other hand, what you're doing is you're projecting over long term an individual's health trajectory. So you would create these health states that are mutually exclusive to each other, and people over time fall into different health states. And what you're doing is you're just tracking where people fall over time into the different health states. And each one has a cost and an outcome associated with it. So that way you can model sort of average cost and average outcomes over time. So we are going to go through an example, and this is where, if you haven't been paying attention already, you might want to start paying attention, because we're going to be doing some hands-on here. So let's focus on this example. So let's pretend that there is a new technology, a seat cushion monitoring system, and in a clinical trial, you observe that in terms of pressure injuries, it reduces the occurrence of pressure injuries by 20%. So that's amazing. That's especially amazing because you know that pressure injuries result in higher economic burden to the healthcare system. And for people who experience pressure injuries, they have a 20% chance of having a bone disease that costs the healthcare system even more money. So there might be some sort of economic argument here because the technology, the new technology, this monitoring system costs $500 compared to standard care, which is only $200. Okay, so that's sort of this scenario. So if we were to translate this to a decision tree, then we would have something similar to this. So we would have an intervention, and when they receive an intervention, they can either have a pressure injury or they won't. And from what we saw in the example, that probability is 30% that they would have a pressure injury. And then for individuals who have pressure injury, their chance of experiencing a bone infection is 20%. Okay, we also have the cost of people who go down these different arms. So if you just receive the seat cushion and you don't have a pressure injury, that's the only cost that that will accrue. If you have a pressure injury but no bone infection, osteomyelitis, then it's only $1,000. And if you have the pressure injury and you have osteomyelitis, then it's $1,500. Okay, these are all hypothetical, even the probabilities, but it keeps it simple, right? So if we were to do the math on this, then we can see that the probability that people will kind of go through each of the arms is 70% at the top, and then their conditional probabilities for people with pressure injuries, whether they have osteomyelitis or not. If they don't, it's the 30%, and then 80% of the 30% will have no osteomyelitis. 20% of the 30% that experience pressure injuries will have osteomyelitis. So once you multiply the 30 with 80, you get the 24%. 30% with the 20%, you get 6%. So you have the different probabilities. And you also have the cost of falling into these arms. So you have 500, 1,000, and 1,500. And so you get, what you can calculate is a weighted cost of each of the arms. And once you've calculated all the weighted costs, once you sum it together, then you get the average cost of an individual who receives the seat cushion. All right? So everyone with me so far? That's great, because we're going to take a few minutes and see if you can complete the average cost for an individual receiving standard care. So I'm going to let you go at it for a few minutes. And in a few minutes, I'm going to present a poll with some possible answers and see if you can get the correct answer. Okay. So I'll give you a few minutes. Oops. Oh, sorry about that. I think I just unshared my screen, right? All right. So here it is.
On a warm summer's evening, on a train bound for nowhere, I met up with a gambler. We were both too tired to sleep, so we took turns of staring out the window at the darkness till boredom overtook us, and he began to speak. He said, "Son, I've made a life out of reading people's faces and knowing what the cards were by the way they held their eyes. So if you don't mind my saying, I can see you're out of aces. For a taste of your whiskey, I'll give you some advice." So I handed him my bottle, and he drank down my last swallow. Then he bummed a cigarette and asked me for a light, and the night got deathly quiet, and his face lost all expression. Said, "If you're gonna play the game, boy, you gotta learn to play it right. You got to know when to hold up, know when to fold up, know when to walk away, and know when to run. You never count your money when you're sitting at the table. There'll be time enough for counting when the dealing's done." Every gambler knows that the secret to surviving is knowing what to throw away, knowing what to keep. 'Cause every hand's a winner and every hand's a loser, and the best that you can hope for is to die final words I found, an ace that I could keep. You got to know when to hold 'em, know when to fold 'em, know when to walk away, and know when to run. You never count your money when you're sitting at the table. There'll be time enough for counting when the dealing's done. You got to know when to hold 'em, when to hold 'em, know when to fold 'em, know when to walk away, and know when to run. You never count your money when you're sitting at the table. There'll be time enough for counting when the dealing's done. You got to know when to hold 'em, know when to fold 'em, know when to walk away, and know when to run. You never count your money when you're sitting at the table. There'll be time enough for counting when the deal is done.
Okay, how is everyone doing? I got some answers so far. So far we have 650. Let's see if that is the results. Let's go back to the slideshow. And the answer is 650. Great job, everyone. Great job. So we have the seat cushion, which is 680, and we have standard care, which is 650, meaning that in the short term anyways, the seat cushion is going to cost more than standard care if we are taking a look at the cost. So, a good argument so far. But, however, you think about it a little bit more, and you think, well, this new seat cushion, it decreases pressure injuries, and pressure injuries are considered chronic ulcers because a lot of people, when they experience pressure injuries, they experience it for a long period of time. Now, I know that pressure injuries cost about $600 per year, and I know that only 20% of people experience pressure injuries will heal at a given year, meaning the majority of them will still remain to have the pressure injuries over a period of time. And if it's $600 per year to treat individuals, for individuals with pressure injuries receiving health care, then how would it look like 5 years from now if we have a system that is supposed to reduce pressure injuries? So let's take a look at our result and extrapolate it over 5 years. What would the results look like? And so for that, we can use a Markov model. So our Markov model here for our example is a really simple case. So it only has 2 health states that a person can fall under. They can either have a pressure injury or they are healed. And we are going to follow a hypothetical population of 100 people, and we are going to follow them over a 5-year time frame and see what proportion of these individuals will be healed or continue to have pressure injuries over time. Keeping in mind that 20% of pressure injuries will be healed per year. So in our first year with the treatment, we say that 30% of the individuals will be healed due to our new treatment. And so that is the 30, the number healed would be, or don't experience a pressure injury is 70%, and 30% will have a pressure injury. All right, so that's in the first year. However, after the first year, 20% of these people with pressure injury will heal. So if we take the 20% of 30, we have 6 individuals who will be healed from that 30 after a year. And of course, they will go into the healed state. So when we move those 6 people then after a year's time, we will have 24 people in the pressure injury health state, and now 76 people in the healed state, right? So 6 people have sort of moved over from pressure injury to healed after 1 year. We do that again for the following year. So 20% of the remaining 24 people now, that is equal to 5, approximately 5, we're rounding here, are going to be healed. So they move from the pressure injury to the healed state after the second year. So when we do the math again, that reduces the number of people in the pressure injury arm to 19, increases the number of people who are healed to 81. And then if we keep doing that all the way down to 5 years, by the 5th year, then all that remains in the pressure injury health state is 10, and 90 people will be in the healed state. All right, so now we have our numbers. Now, remember what we mentioned earlier, the people in the pressure injury state, in terms of healthcare use, is $600 per year. So if we were to then multiply the number of people in that health state, the pressure injury health state, by the cost in that health state per year per person, then what we come up with is we come up with a sum of $66,000 for this cohort of 30 people dwindling down to 10 people over a 5-year time frame, right? So 600 times 30, 600 times 24, 600 times 19 gets us these numbers. Now, of course, this Markov model could be a bit more complex. Maybe people in the healed health state also have healthcare use, and so there will be a cost associated with that, and you would sum that as well and sum the total. But we're going to keep it simple. We're going to say it's $0 per year in the healed state, and only people in the pressure injury state have a cost. And so it costs $66,000 for 100 people. So that means that it's on average about $660 per person for healthcare for an individual who receives the seat cushion and their probabilities of being healed or receiving a pressure injury. And that is the average cost over a 5-year time frame, $660 per person receiving the seat cushion. Okay, now you know what's going to come up next. We are going to now try doing it ourselves for the standard care, right? So back to your Excel spreadsheets or whatever you're using, or even a calculator on your phone. We're going to try and do this. I'll give you a couple of minutes, and then we are going to take it up, and then I'll throw in a poll to see if you get it, and we're going to take it up.
Money, 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 money. The only thing that's on
Okay, I'm going to stop it early because I think most people have responded already. And all you guys got $996. So as you can probably guess, that is the correct answer. Good job, everyone. That's pretty good end of the summer and everyone's still ready to do math and doing a good job. So now here are results. If we look at the short-term costs, then the seat cushion was more expensive. But if you then think about the long-term implications, the long-term costs, and we were to extrapolate costs over time, you can see that the results have changed, right? So there are some benefits to looking at things in the long term, especially if there are long-term impacts. So good job, everyone. You guys did a great job doing this. And we are going to move on to the next part. And that is to talk about some of the challenges of conducting economic analysis when we're dealing with monitoring technologies. Let's start off with a question. So if you were to cost out a monitoring technology, what would you include in your cost analysis? And here's some options here. You can collect all the costs that you can possibly collect in a clinical trial. So run it with a clinical trial and just collect all the costs, and that way you cost out the technology. Or maybe it's all these costs from the clinical trial, but you have to exclude the development costs, so the cost of developing the technology. Or maybe it's none of the clinical trial costs can be included. All you have to do is you have to include all non-study related costs. So let's stop this results and let's see what people think. What would you include if you're costing out technology? This is a short one, so I don't have any music to play with it. Okay, so I'm going to end the poll and share the results. And as you can see, it was a mix. Given our small sample here, we have a mix. More people said all the costs you can collect in the clinical trial, 2 people, but then 1 person each said the answer 2 and answer 3. And this is not surprising, given that even people in the field don't necessarily agree on this issue. Now, what happens in reality, typically, is that we cost out the technology based on what we collect in the clinical trial. So it's usually piggybacked onto a clinical trial and we collect costs and we present it as the cost of the intervention. However, some people have mentioned we don't necessarily present or include the developmental costs because the developmental cost is not a cost that would accrue if this new intervention were to be adopted by a healthcare system. However, other people have argued back saying, while these are part of the costs of having the intervention, this intervention would not exist without these developmental costs, so they have to be incorporated somehow. And then some other people have argued, well, it doesn't even matter because the costs in the clinical trial do not necessarily reflect reality. In a clinical trial, you have many more follow-up than you typically do in reality. There are a lot more other costs that are incorporated to continuing monitoring the individual that won't happen in reality. So a lot of these costs don't occur in reality, and we want to get at the real costs. So clinical trials, we shouldn't include any of those costs. That's the difficulty with costing the technology, because what you have to think about is whether you have incorporated all of the costs of the technology and it's a true reflection of reality. So for people who collect the cost in just the clinical trials, they may be only collecting one aspect of the cost and not necessarily collecting the cost of implementing the technology in the next next long-term care facility or in the home care setting, for instance. There are costs that occur in a clinical trial that don't necessarily occur in reality. And we want to try and, I guess, mimic reality as much as possible. But without these clinical trials, it's hard to know what the costs actually are. So there are a lot of different issues, even just to find out the cost of the technology. And that requires a lot of work, and sometimes some people can collect a few costs and only show a portion of the entire cost of technology. The other issue is outcomes. And outcomes are important. When we're talking about economic evaluations, cost effectiveness analysis, we talked about splitting the outcomes with the cost. So there are costs associated with the new treatment versus comparator, and then there are outcomes, and then you put it together in a result that shows cost per the incremental outcome. And I mean, that kind of holds true with monitoring technologies. However, in the case with monitoring technologies, in many cases, you are preventing complication from occurring. And so if we are preventing it from happening, then that may in some ways be difficult to try and translate into outcomes. It could be a cost per, let's say, a falls avoided. So that could be an outcome that can be used when looking at that monitoring technology. But even more powerful would be if we were able to cost out falls and then take a look at the cost of the technology versus the cost of the falls avoided, right? And so in that case, what we need more information of is the cost of illness. So getting back to the types of economic analysis, the last one I mentioned was cost of illness. That, I think, is a important and a powerful analysis when we're dealing with interventions that prevent secondary complications. Because if we can cost out how much that illness or that condition would cost the healthcare system over time, if we are to prevent that, then you have potential cost savings. And you can compare that with the cost of providing the intervention or the technology, right? So here's a question. So for cost of illness studies, what should you be interested in? I'm going to pull this into a polling question. What should you be interested in? Should you be interested in the total cost of the illness itself? So the entire cost an individual has a certain condition, all the healthcare costs associated with it? Or should you be interested in the additional cost of this illness versus a person who does not have the condition? Or the third option is, it doesn't really matter because cost of illness studies are meaningless. So be interested to see what you think about this. Okay, we've got quick responses, so I can end this poll. And it seems that most of you think that it should be the healthcare costs that are associated with the illness. Okay, so these are the additional costs as a result of the illness. And we also got a vote for the total cost of the illness. Now, also, once again, not too surprised that there's a variety of results, because even with researchers who do this, there is some back and forth controversy about which should be calculated. So some say that you should calculate the total cost of the illness because that is the cost that affects the healthcare system. And it's also, of course, the easiest way to calculate costs. You follow up a cohort of individuals with the illness and you follow them over time, and how much does it cost the healthcare system? That's how much it costs. However, some people have said, well, that's not entirely accurate, because that this individual, if they were the same individual were not to have that condition, they would still have healthcare costs over time, right? With other illnesses that that may occur over time. So we should be only looking at the incremental, the additional cost of the illness itself, and not the total cost of the illness itself. And those types of analysis are a bit more complicated. So now you have to deal with a comparator arm. You have to make sure that the two groups are very, very similar. And then you can calculate the healthcare costs of the two groups over time and subtract the difference between the two. There's also another group of individuals who do economic analysis who say, well, these results are actually, cost of illness studies are actually meaningless, because if a person were to have the illness, then it means that if you were to prevent it entirely, then they would have absolutely no costs associated with the illness, and we can't be sure of that. They would have other conditions that would occur that would have resulted because they did not have that illness. So there's no way to knowing what the cost of illness really is. And I mean, their justification sometimes for that is if for the cost of illness studies that have been conducted showing, this illness costs the healthcare system a certain number of $1 million per year, if you were to take a look at reviewing the entire literature, take all the different conditions that have cost of illness studies associated with it, take the totals, sum it all up, it would be about 5 times the healthcare budget. So there's absolutely no way that any of this can be accurate, because we're not spending 5 times our healthcare budget in reality. So there's something wrong with these analyses. And there's some truth to that. It may be a result of some of these studies not being conducted very well, but sometimes these people go a bit too far and throw the baby out with the bathwater. So there is some controversy on this. I advocate for the healthcare costs associated with the illness, so the additional cost. I don't think that it's meaningless, but the additional cost is what you're trying to prevent. If you prevent the condition, the person will still continue having healthcare costs, but it's the additional cost that we're after. Okay. Thank you very much for that. So you can tell that after the discussion today, there are possible opportunities to work together. Definitely, if you want to move your intervention from showing a improvement in clinical outcomes to one where you want to see if it's economically feasible for a healthcare decision maker who funds technologies. Definitely, there may be some opportunities to work together to look at explore whether we have the evidence required to put an analysis like that together. And I hope that I will be able to work with some of you in the future. And what is next? This is actually potentially part one of a 2-part presentation. Originally, we were hoping to put 2 of them together into one, but our analysis isn't ready. Alyssa and I are conducting a review of all economic analyses related to tele-rehab. And so that's kind of related to what we are talking here. And we would be very interested in presenting the results in a future workshop. And we're hoping to get this done by the end of the year. So if Jose is willing to let us back, maybe we will talk again in the future and continue our conversation and show you what the literature shows in terms of economics and tele-rehab. Okay, so thank you very much. Appreciate your participation in the hands-on parts and for your attention, and happy to take any questions that you may have.
Thank you very much, Brian. It was very educational. I learned a lot. Floor is open for questions if anybody has any. Maybe I'll start us off. So, not sure this is a question or a comment, but in terms of costing and technology, so sometimes I guess there's the kind of definite costs, and other times I guess depending on how we develop technology, what features we include, how we manufacture it, the cost might be very, very variable, right? So I guess I imagine in some cases it's an issue not so much of what is the cost, but what would the cost need to be for this to have a positive cost benefit kind of analysis, right? Um, so is that an approach that is like commonly taken in the health economics literature? Do people do those types of analyses, or is it mostly like this is the cost of the intervention and is this worth it or not? Or if we wanted to do that kind of analysis, I guess the question, would we approach things differently, or are there other considerations that we would?
Yeah, no, that's a great question, and that is the type of analysis that's generally conducted, I guess I would say, behind the scenes or during the development of a technology, and usually done in companies and industry to judge whether an intervention or a technology that they're interested in pursuing, whether it's worth pursuing, right? And so those tend to be analysis that are done internally as opposed to something that would be published in a journal paper. However, those tend to be very, very simple analysis where they would take an outcome, a single outcome, usually a primary outcome, take a look at what the cost impact is, and then take a look at how much their intervention should cost to sort of break even, right? So those analyses are done. They typically are done behind the scenes. For a full economic analysis, then it needs to be a bit more sophisticated where you have to consider all the options. And then sometimes there are what we call sensitivity analyses, where we kind of vary some of the inputs and the amounts that are in the inputs. So sometimes the cost of the intervention is one of those inputs where you create a range of values, potential values, a range of values, and then take a look at how that impacts the results. So that's where it would be included in something that will appear in a journal paper. But typically, a lot of these analyses are actually done behind the scenes.
Thank you. We have a question from Avril, so I'll just read it out. Thanks, Brian. You talked about how to estimate the costs, but how about estimating the probabilities and possibilities? For your example of pressure source, presumably bone infection isn't the only consequence to consider.
Right. So that is where there needs to be a review of the literature in terms of the epidemiology of the condition that you're looking at. So in the case of our example, pressure injuries, you're right. It's not going to be one single outcome that or secondary complication as a result of a pressure injury. So that is where a more fulsome review of literature in terms of all the possible complications and what the observational studies have shown in terms of incidences of those secondary complications, the probabilities of them occurring over a short-term period as well as a long-term period needs to be conducted so that you have a more robust tree or a Markov model. Ours was a super simplified example. If I was to add one or two more secondary complications, that would make it way more complex than it needs to be. But in reality, it is a bit more complicated than that. Sometimes you can incorporate all of that into a cost, for instance. If somebody has calculated the cost of illness of a pressure injury, and so when they follow up cohort of individuals with this condition over time, it takes into consideration all the secondary complications and all the healthcare costs associated with it, because that person, a portion of it would have experienced it and there would be costs associated with it. And so that gets all wrapped up into the cost in the cost of illness study, but it doesn't in terms of if you want to map out the outcomes and you don't have a cost of illness and you have to sort of cost the condition yourself using a decision tree or a Markov model, then you have to get into the epidemiology.
Thank you very much. Any other questions? I have another one. So when you're calculating the cost of the not the standard of care, but the implementation of the new model, would people typically, like, how complex would you get with that? Like, would you just sort of add the cost of technology, or would you try to model how the system would change? Because if they're doing the new piece, presumably maybe there's something else they're not doing, or you're trying to just add something and not take anything away. Like, does that have to be modeled in more detail to understand how the whole picture changes? Or do people just typically say, okay, technology itself costs X, so we're just going to add X to the cost?
Yeah. So some of that is typically addressed when you are comparing it with a comparator. So typically your comparator is what is the most likely intervention that a person would receive if they were not to receive the intervention that you're looking at, right? So when you cost that out, by looking at the difference between the two, the incremental costs, what you're doing is you're saying, if you're taking this new technology, you're removing that old technology out of the system. And so you get at the incremental cost between the two. Now that's sort of an oversimplified way to think about it, because in reality, it's a little bit more complex than that. And sometimes you want to, as much as possible, incorporate that into the cost of the intervention. So there's the cost of intervention. It reduces, let's say, follow-up visits or physician visits or visits to the outpatient clinic or whatever. So that would sort of be incorporated into the cost of the intervention. It's sort of like a byproduct of having the intervention itself. And so, so that's how those components are integrated into an economic analysis. However, it can get quite complicated, and you sort of have to balance how accurate do I want to get to how certain or uncertain am I that this is a reflection of reality. So it's always that balance as well, incorporated in the analysis.
I guess kind of a follow-up, a related question. So how would you deal with upfront costs, like one-time fixed costs? So say, for example, the institution can save money, but they have to first invest in updating their electronic health record, or they have to do something to get set up for telerehabilitation. So it's not necessarily cost per patient, but there's the initial infrastructure type of cost.
Mm-hmm. Yeah.
Is that incorporated typically, or
where the extent possible, it should be incorporated. The reality is it's very difficult to get at that. What some people have done is they've taken the capital costs, so the upfront costs that an institution will have to do to create the infrastructure required to be able to deliver the intervention, and then they would then take a look at during a certain period of time, the number of individuals who had received the intervention, and then sort of proportion out that upfront cost to those individuals as a way of costing out and incorporating that cost. But it gets very complex, because then you have to start doing measurements of how many people should receive the intervention, how long will the infrastructure last until you need to repurchase, and then you have to then calculate what the amount is per person over time. For some interventions where there's a large amount of throughput, that it might end up being very little in the long run, potentially. But if it's an intervention where there's a small niche population, then it can be a substantial, it can change the analysis substantially if that wasn't incorporated. So, and there's also other issues as well. So like how are these costs being provided for? Is it through like donations? Is it through a foundation? And if so, should that be incorporated as costs, or if it's donated, then maybe there is no cost associated. So it gets a little bit more complicated once you incorporate those aspects to it, but where best possible, it's best to include it.
Thank you. So one last question here from Vijay. So hi, Brian, thank you for the great talk. I'm wondering why the cost of development is not included in costing up technology, or how the cost of development is reflected in the cost.
Right. So some have argued that development cost isn't incorporated in the cost analysis, because what you're trying to present in the cost analysis is the cost of providing this intervention to the next person. So if we have this technology and there's a cost associated with the research and development of it, and you now have a version of it that will kind of move forward. Then if this was to then be integrated into the next place, so that being a long-term care facility or hospital or whatever, that hospital or long-term care facility will have certain costs associated with the intervention, providing the intervention, but they won't have those developmental costs. Those are sort of, I guess, sunk costs, right? They've occurred and they're not occurring over time. And so that's why some have argued that we shouldn't include it. However, other people have argued that there is a cost associated with that, right? Because there was research, and without those research costs and whatnot, this intervention would not exist as well. And so it should be somehow incorporated. And so actually adding it into the analysis in reality is very difficult again as well, because then you have to figure out how to cost out all the research dollars required to develop an intervention, and then how to spread it over all the people who would benefit from that intervention. And then, of course, the other issue is, where did those research dollars come from? Did they come from sort of the public funds and whatnot? And so it can get complicated in terms of how to do it, because of the problem of putting a cost amount to the research and everything else that was occurred for development, and also how to then distribute it over all the people who could benefit from it.
Wonderful. Thank you so much, Ryan. So I think we're out of time. So thanks again for your great talk, and thanks for all of you who attended. And we'll look forward to the telerehabilitation part 2 when it's ready.
Yeah, and do email me back. I would really enjoy or really appreciate any feedback about what worked, what didn't, because I tried a lot of new stuff, and look forward to potentially seeing you in part 2.
Thanks, Brian. All right. Bye, everyone.